जैसे आपने कहा कि नथिंग इज 100%, देन व्हाई इज शी ऑपरेटिंग? तो ये बेसिक फेलियर तो सीन में है ही, वी ऑल नो दैट इट मे फेल.
We can also minimize the chances of failure by taking the maximum precautions.
And that is why we have put bitterly.
More precautions.
How much more?
That void that because it is not able to.
Then there are no limits. I usually wash my hands only till this part. Is it correct? Of course, boss is always correct. But beyond that, how far away do you go? What is the limit?
Till there.
No, why not till the armpit?
So because this is the actual reason and we are keeping a little bit of margin.
But we are not operating uncovered. Actually, this came up from the notion that earlier there were no gloves. So जो गुरुओं के गुरु थे, वो बिना ग्लव के ऑपरेट करते थे. So it was a convention that you had to wash your hands. But times have changed. But we have not changed. Why? Because we follow the guru ka guru ka guru. Your teachers tells you, अरे यहाँ तक नहीं धोया. लॉजिक नहीं है, डिस्कशन नहीं हुआ, कोई इस पर रिसर्च नहीं हुई, कोई केस कंट्रोल स्टडी, कोई कोहॉर्ट स्टडी नहीं हुई कि साहब आपने ऑपरेट किया यहाँ तक धो के, आपने ऑपरेट किया यहाँ तक धो के. एक आदमी आया, वो नहा के आया और फिर कंपेयर किया. देयर इज नो स्टडी, इट इज़ जस्ट अ नोशन. किसी ने कहा साहब उन्होंने ऐसा किया था तो हम भी करें. बिलीव मी माय फादर has quit operating, but when he used to operate in front of me, he didn't wear gloves. No gloves. Whatever the patient, no gloves. Why? Because he was from that era where the gloves are very expensive. So he had to compromise with that, and it is now his habit. He has quit operating. रोशनी में देखिए, सामने जो रोशनी है, इसी को देखेंगे. आँख हिलाइएगा नहीं अब. उसको फेस डाउन करा दिया. कैसे बताया उसको?
सर पेट के बल लेटने बोला और सर ऐसे हाथ के ऊपर रखने बोला.
यही तो गलत इंस्ट्रक्शन है. पेट से हमें क्या करना है? अगर वो कुर्सी मेज पे बैठना चाहे तो
हाँ सर, उसको बताया है कि अगर बैठना चाहे तो खुद छाती की तरफ जाके बैठ जाए.
नहीं, इम्पोर्टेंट ये नहीं है. इम्पोर्टेंट है उसको तुम ये बता दो, वो पेट कर ले जाएगा और करवट ले लेगा सर से. उसको बताओ कि माथा और नाक ये बिस्तर से लगाना चाहिए. अब इसके लिए चाहे तुम्हारा बाकी रेस्ट ऑफ द बॉडी में भी इन एयर, में भी इन ऑन टेबल, में भी ऑन बेड. हैव यू एवर assumed this position ever? यही फेस डाउन. हाँ, for long. It's very uncomfortable. यार ये ग्लो अच्छी नहीं आ रही. अब ठीक है, मैंने ही ऑफ कर रखा था. The problem is that this fact that do we need to wash our hands up to the armpit or up to the elbow, this has never been challenged, because those who were practicing this are the people whom we are following blindly, and at times it is like slightly discourteous if you challenge somebody's faith. But I usually don't wash my hands till elbow. But yes, you have to learn to wear gloves properly so that you don't touch the outer surface with your skin. Ah.
801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801. 801.
Mhm. Soft cataracts have a problem. There's nothing to hold on to. They split. The portion which you are trying to hold will simply cheese wire. You're left with a very big crater. It is like clay. You cannot pull clay towards you. You hold the clay and you pull, that piece will detach. It will come to you. Here we want to have rest of that tissue also come to us. But rest of the tissue is so soft, it doesn't bother to come to us. And that is why at times it is reasonable that you simply let the nucleus be prolapsed out. Because in the bag you don't want to take that risk. Cornea wet. ये तब से सर्जरी चल रही है जब से मैं आया हूँ. क्या कर रहे हैं लोग? पेशेंट भी थक गया है.
लेंस खोल दीजिए भैया.
मुझे लगता है ये उसका है, पुराना वाला ये है, ऊपर से लीक कर रहा है. आइए बोला दिया करो, एल्कॉन वाला, वो ऑप्टिकॉन वाला, ये लीक करता रहता है. और इसके लिए कुछ आया ना था, बन के रिप्लेसमेंट आया ही नहीं था. This is the most dangerous part of cortex, subincisional part. Usually results into a PC rent because then you are pulling something with blindly, and that too with a machine. Machine will not have any proprioception. If it holds the PC, it will hold, and you pull, it will tear. So usually people leave behind this portion, and no, you can put the IOL first, and then IOL will provide that shield so that you can work over it, and then you can safely, it will keep the PC away, rather it will shield the PC. So always, if you have trouble removing that, put in the IOL, and then you can do it safely. But at times you can have the cortex trapped between the PC and the IOL. That is little more tricky. So you should scoop it away first, and you can always use the IOL to do that job. You can use the IOL itself to scoop it up. Someday if it is there, I will show you how to do it. Rather, if you go to my channel, you will have some video regarding this. Not only that you remove the visco using IA, but you also flush it. See, there's so much of left behind. So let this be flushed out. So your infusion itself, there's a fiber there, see this fiber. Let it be there. What do you think this fiber is composed of? Take a guess. Does it look like cotton? एक सुन का इंजेक्शन दे रहे हैं, सर ना लाइएगा. It's not cotton. Look at it carefully. Is it cotton? Is it? It's not opaque. See, it is refractile. Cotton is never like this. Is it like? This is plastic, I think. It is a very specific green color all the time. Whenever you find this, it will be green color. I think it comes from the syringe. I don't know.
Maybe it's a part of the IOL.
No, it is not part of the IOL. IOL doesn't have this kind of plastic. So I was wondering if she would complain of pain. She didn't. What does this tell us?
Continuous irrigation of
Good anesthesia. She has turned her face towards this side. ऐसे सर इधर रखिए, उधर मत घुमाइए, दवा दूसरी आंख में गिरने लगेगी. इरिगेट करो इधर.
continuous irrigation of left one on.
I wish I had 2 macular holes per OT, and it would be such a comfortable scenario for me. इन्फ्यूजन ऑफ है क्या? प्रेशर नहीं आ रहा. कटर दीजिए, TMA दे दीजिए, TMA दे ही दीजिए. बायोम nice. Focus.
FAEL.
अरे लगा दो, डिवॉश हो जाना, फिर से वॉश हो जाना. नहीं नहीं, यहाँ पे क्या चल रहा है? तो उधर बगल वाले कमरे में लगा दो. हाँ, और डिवॉश हो जाना, फिर से वॉश हो जाना. सुबह से बैठाए उसको, वैसे भी उसको कल लग जाना चाहिए था. है ना, एक तरफ तो कह रहा है एंड ऑफ इमरजेंसी, उसको 24 घंटे देर कर रहा हो, अभी भी 2 घंटे देर कर रहा हो. So we are trying to do core vitrectomy right now. We are not yet at the posterior pole. We'll do that also. Just once we have finished cutting all these connections, anterior-posterior connections, and you will see that effect. The translone, which is now tethered to the vitreous, will start floating freely. See this? Now it is floating freely. And this is what we want. We want this vitreous cavity to be free of its previous occupant. And I can see this is abnormal vitreous. This is like membrane, like a sheet. And you can also see these shimmering surfaces. This is all abnormal adhesion of the vitreous over the retina. No, this is not translone. This is because of interface abnormality. And now we will proceed on for removing this. So we switch to vitrectomy 2. Cornea wet karo. पूरा cornea करो. You can do this quickly. You don't need so much time for this. Cornea कितना surface area होगा? Yes. 12 by 12 है. कितना एरिया होगा? 12 मिलीमीटर के सर्कल का. So this is vitreous attached to the disc, and we are trying to pull it using maximum possible. So you see, we have now engaged this, and you can see there is some abnormal adhesion here. And this seems more like a congenital problem, not like acquired one. And now we have detached it fully. So whole of the posterior vitreous face is now detached. You simply consume it because now it is away from retina. Safe to do it. And now our retinal surface is naked, no vitreous over it. And now when we reach to it and touch it, we will be touching the ILM. Nothing in between.
Vitrectomy 1.
Cornea. Problem with cataract surgery before vitrectomy is that when you do cataract surgery, part of your cornea becomes slightly hazy. So when you view through cornea, you find that at times especially in the inferior view, you find that the view is not very clear. Air pump will cause some edema and hemorrhage here. Air pump, हाँ होल है डिस्क हेमरेज में. एयर पंप,
Phacoemulsification. Continues irrigation off.
एंड नाउ वी हैव एयर. फोकस करिए. रुक जाओ. अब फोकस करो. कॉर्निया मिट करो. डाई. दो मिनट देखो. 2 मिनट देखो. क्लॉक देखो. This will bring the microscope to default. Center कर देगा, focus up down zero कर देगा, zoom zero कर देगा. So basically to reset all the motors. See, when patient is moving here there, you are moving here there, then at times you reach to the limit. So I had reached the limit of downward movement. So I couldn't focus or couldn't bring the microscope further down. Keeping the lens as close to the cornea has a big advantage that your field improves. The further away you are, your field is narrower. So you want to be close to the cornea as possible. But it has a disadvantage. You may touch the cornea. You don't want to touch it, because then your lens will get some fluid film. It will compromise your view. And when you repeatedly clean the lens, it gets scratched. So you don't want to touch the lens to any surface. So when you are moving all these things and you find that you are reaching the limit of the microscope, then you manually adjust. But then you will have to pull out the instruments. So now there is a pause and we can do everything what we want. So now it is 0. I will bring it down as close to cornea as possible. कटर ये हटा दो, इसकी ज़रूरत नहीं होगी अब. विल स्विच टू लैंडर्स. कटर कहाँ गया? Now we want this air to go. We want ringer to come.
Irrigation on.
इरिगेशन ऑन करिए. देखो क्या कर रहे हैं वो. You will fail to learn.
FAEL.
कॉर्निया वेट करो लैंडर्स now this is one very simple device plano concave lens. It neutralizes the power of cornea and it makes the retina visible to us without any aid. The beauty of landers is that you have very crisp, undistorted vision, and the best part is that I can control the focus now, which is so very important when you are working at such a high magnification. So this is known as pinch and peel technique, where you hold your breath pinch the surface create a flap and you start peeling the iron. You always try to peel it towards the hole. Low finger low. So that actually you can also iron the hole and pull the tissue toward the center. My microscope optic is getting fogged. When I'm very now this is a large chunk of ILM. पंखा तेज करो यार, ये वाला.
रिकॉर्डिंग बंद हो गई स्क्रीन.
Even the breathing movements of the patient are causing me to take note and synchronize with her breathing actually. Because I don't want to touch the retina surface. I want to limit myself just to the ILM. So I have to synchronize with her breathing. I can feel her breath, movements of her head, and I synchronize it accordingly. We want ILM to be as atraumatic as possible. Now we have large chunks of ILM. We have it. So we have peeled up to the arcade on this side. We have not yet peeled up to the arcade on this side. We will just extend this little further. Cutter. Biome. Cornea wet. Biome. Focus. हो गया हो गया हो गया. So you see, it was appearing such a large area which we had peeled, but now you can see It is just the arcade and rest of it is still there, but we are not bothered by that. This is good peel. Air pump. Now I left behind this ILM attached to the margin of the hole.
Continuous irrigation off.
Now we'll stuff this over, we'll drape this over the hole. So this is also known as the inverted flap technique and adopted for large long standing holes. So the same factors which will causing the hole are now inverted. है ना, uno inverse, reverse. वो लाओ, फोकस करो, बस. So we drape this ILM, but this has to be very carefully done because you may actually pull the ILM into your cutter. Because fluid is flowing towards your cutter and ILM is just very faintly attached to. थोड़ा फोकस चाहिए ज़रा सा, एक्चुअली व्यू ही खराब हो गया. कुछ है गड़बड़. लेंस माप करो, कॉर्निया वेट करो. This is better. So if you place your cutter on this side, you will find the flap will come to this side. And we have consumed some of the flap. And we can't do anything about it now. It's a very delicate job because I cannot use the cutter to push this flap over it. If I have to use, I have to use some soft tool. And if you aspirate it too fast, it will simply come into your port. More so when first of all, let me make this surface dry, and then this will behave properly. And I cannot see. डायमंड टेस्टेड मेम्ब्रेन्स के सिलिकॉन टिप कैनला या DDMS दिए, इसको खोलिए. देखें क्या है इसमें. सिलिकॉन टिप है इसमें? नहीं है. और कुछ है? फोर्सेप दे दीजिए. और कुछ है कहीं पे? कोई सामान कहीं और रखा है? फोकस करो. कॉर्निया वेट करो. ये लेंस भी थोड़ा गंदा है. छोड़. Let, I have so much desire to drape this flap over the hole, but I know that this is going to be very difficult. वही येलो लेंस लगाई है, इसकी एक्स वाई जो फोकस स्पीड है ना किसी ने कम कर दिया वहाँ से, इसके धीरे धीरे ऊपर जा रहा है. फोकस it's all blind actually. The moment I touch, the fluid causes so much reflexes. कटर दीजिए, कटर से ही हो सकता है और कोई तरीका नहीं है. Now the view is even more